Good afternoon. My name is Onyinye Balogun, and I'm a radiation oncologist at Weill Cornell Medicine and New York Presbyterian Hospital. Today, I'm excited to speak to you on the topic of the tale of two cities, disparities in radiation therapy for breast cancer. I have no disclosures to report. My goals are to review the evidence for radiation therapy in breast cancer, and also to describe the disparities in the use of radiation therapy for patients with breast cancer. First, I'd like to take a poll of the audience. I'll read a statement, and I would like you to select if you think it's true or false. In New York, all women with breast cancer are equally likely to receive radiation therapy if they need it. Is that true, A, or false, B? First, I'd like to review the clinical studies that show us the benefit for radiation therapy in breast cancer. You may have heard of something called DCIS, or ductal carcinoma in situ. This is a precancer that arises in the ducts of the breast. It's not a true cancer because it has not gained the ability to travel outside of the breast to other body parts. But we know that this precancer is important to treat because it can progress to invasive breast cancer. In this analysis of multiple studies looking at thousands of women with DCIS, we see that on the left, in women who do not receive anti-hormonal therapy, sometimes called tamoxifen or other drugs, we see that if radiation therapy is given after surgery, it decreases the likelihood of DCIS or an invasive cancer coming back by 50%. The same is true even if a woman receives anti-hormonal therapy, as shown on the right. In this study, women who only received surgery, 18% of them had DCIS or an invasive cancer come back, whereas about 9% of the women who received radiation therapy had a DCIS or invasive cancer develop in the future. When it comes to truly invasive breast cancers, we also see a definite benefit for radiation therapy. Looking at the upper left corner, this analysis of tens of thousands of women, over 7,000 women, showed that those who did not have lymph node positive disease, meaning that the breast cancer had not yet gone to their lymph nodes, by receiving radiation therapy, again, they decreased their risk of cancer coming back by 50%. In addition, we see that radiation therapy in the upper right-hand corner also decreased these women's risk of dying due to their breast cancer. The same is also very true for women who have more advanced disease, women who have lymph nodes that are positive for breast cancer. In the bottom row, you can see on the left that by giving radiation therapy after surgery, there was a decreased risk from 64% to 43% of women having cancer come back. Also, 50% of women who did not receive radiation therapy died of their cancers after 15 years, compared to about 43% of women. So consistently, radiation therapy decreases women's risk of dying due to breast cancer or of the breast cancer coming back. Unfortunately, this important treatment is not given to all women. There have been multiple studies showing that there are inequalities in terms of access to radiation therapy and receiving radiation therapy. In this study that looked at Medicare patients who are 65 and older that were treated with breast conserving surgery, meaning they did not have a mastectomy, who had been treated for breast cancer in 2003, we see evidence of inequalities. Out of over 34,000 women, we saw that 74% of white women received radiation therapy. In contrast, 65% of Black women and 66% of women of other races received radiation therapy. Therefore, white women were 1.5 times more likely to receive radiation therapy. And you can see that in this map of the United States of America, that the likelihood of you getting radiation therapy varies from state to state. The states that are colored in white don't have any differences in terms of radiation therapy receipt between white and Black women. The darker the state is, unfortunately, the larger the difference between the percent of women who receive radiation therapy and those who are Black that do not. And you can see that in the upper right corner where New York sits. New York, New Jersey, Pennsylvania actually had a significant difference compared to other states in terms of the receipt of radiation therapy for their Black and their white patients. Interestingly, once women began radiation therapy, there were no differences in terms of completion of radiation. 85% of white women completed their radiation therapy, and the same percentage of Black women completed their radiation therapy. In addition, 82% of women of other races who receive radiation therapy completed it. So once women begin the right therapy, they complete it. That's why it's so important that we make sure that women access this treatment. So that study was from 2003, and individuals wanted to study if these disparities, these inequities had gotten better over time. This study comes from a group at Yale University who looked at another database between 2004 to 2009. They studied over 67,000 women who were between 40 to 85 years old and had undergone lumpectomy for stage 1 breast cancer. In 2004, they saw that there was an 80.6% rate of white women receiving radiation therapy compared to 78.9% for Black women. Over time, the use of radiation therapy decreased for all women. However, there were still differences, notable differences, in the percent of white women who received radiation therapy for their breast cancer and Black women who received radiation therapy. So unfortunately, these disparities in radiation therapy have not gotten better over time. To add insult to injury, we are now faced with COVID-19 in New York City and in other parts of the world. When COVID-19 began, my colleagues and I were very concerned because we feel that COVID-19 has the potential to worsen these inequities in terms of breast cancer treatment. Nationwide, the breast cancer mortality rate is 40% higher for Black patients compared with white patients. In New York City, this inequity has gotten worse over time, from 19% to 27% between 2005 to 2014. And we believe that unfortunately, the COVID pandemic may only worsen things. The reasons we hold these views are multifactorial. First, we know that minorities are more likely to work blue-collar jobs. Therefore, they're going to have to go out into the public, and they may not have the luxury of staying at home or accepting a cut in their pay. They do not have the economic security to just stay at home. So they have to be in contact with the public, which increases their risk of contracting COVID-19. We also know that if they're going to these jobs in New York City, frequently they're depending on public transportation, which also increases their exposure to other individuals who may be carrying COVID-19. We also know that minorities have higher have higher rates of comorbidities like hypertension and diabetes, which put them at a higher risk of contracting COVID-19. So imagine if you are a breast cancer patient working a job that you can't afford to stop, taking public transportation, and you have comorbidities on top of that. If you contract COVID-19, we're not going to be able to continue your radiation therapy or any other treatment that you need. We'll have to wait until the COVID-19 is dealt with and resolved before we proceed with your cancer care. And that may contribute to disparities in breast cancer outcomes as time goes on. But we're hoping to find ways to decrease and diminish the risk of worsening breast cancer outcomes when we're comparing our different patient populations. One of the strategies, I believe, is to shorten breast cancer treatment regimens. And I believe my colleague has talked about shortening these treatments earlier. So I just want to quickly review this aspect that may help women get the care that they need. For many decades, women received 6 weeks of radiation therapy for their breast cancer after undergoing surgery. During COVID-19, we began to implement these shortened treatment regimens in a more widespread fashion. We've been studying these shortened treatment regimens for over 2 decades, but during COVID-19, there was a definite uptick in practitioners using these shortened regimens. And I just want to bring to your attention what they are again. First, you may be able to receive 15 treatments total, or you may get 16 treatments rather than 30 treatments total. In certain cases, your practitioner may be able to give you 5 to 6 treatments so that you can finish your radiation therapy regimen in about 1 week. In certain individuals who have very early stage breast cancer, we can even opt to just treat part of your breast. And if your clinician decides to treat just part of your breast, you can finish this treatment by receiving radiation therapy on a daily basis or every other day. And that can be given in 5 treatments. In addition, your clinician may opt to give you 2 weeks of treatment just focused on the area where the cancer or the tumor was removed. So there are multiple options when it comes to breast cancer radiation therapy. And I want all women to be aware so that if you're presented with a 6-week treatment option, bring it up with your clinician and see if it's possible for you to be treated for a shorter period of time. Because if you come in less frequently, it will decrease your risk of exposure to COVID-19. And in general, leads to probably a better quality of life. So I will wrap up this presentation by once again asking the poll, taking a poll. Once more, the statement is, in New York City, women are equally likely to receive radiotherapy if they need it. Please select A if based on my presentation you think this is true, or B if you believe this is false. In summary, radiation therapy decreases the risk of cancer coming back or a precancer coming back, and it also improves survival. Black women are unfortunately less likely to receive radiation therapy for breast cancer. One of the ways that we can address this issue, in addition to spreading education and information, is by offering women who may be concerned about the time commitment shorter treatment regimens during COVID-19 and beyond. And we certainly need to continue research to evaluate any existing disparities and ways to address them. Thank you so much for your time and enjoy the remainder of the conference.